Hi guys, we're gonna start. This is a session sponsored by Abbott, From Access to Annulus, Overcoming Challenging Anatomies. I have with me Dr. Wael Kashkari and Dr. Mukhaini, who's gonna talk to us and show us a recorded case with the Navitor FlexNav system. And the objective of this session is to show you, to know more about the Navitor system, how it's function in horizontal anatomy, and future coronary access with this valve. Okay.
It's so great to have such a valve meeting, and then, the company participate and they show you the latest in their devices. We are lucky to be with you and to have such a great session.
Thank you very much, Dr. Wael, Dr. Fadi. I'm presenting two cases. One of them live in a box using Navitor system. The first case will be live in a box in a horizontal aorta. So we'll start. Hello, everybody. My name is Mohammed Mukhaini, interventional cardiologist from the National Heart Center. We are presenting an interesting, challenging case, TAVI, using a Navitor system. Before we start presenting the case, I'll introduce you to the team with me, Dr. Mohammed Barakat Riyami, Dr. Khalid Al-Saidi. Now, Dr. Khalid will introduce the case.
Okay, can we have the slides, please? Okay, next. Next. So we have no disclosures for this case. So we have an 83 years old gentleman with past medical history of diabetes, hypertension, and benign prostatic hyperplasia. This patient presented with exertional shortness of breath, NEHA class 2, and he was found to have severe aortic stenosis, tri-leaflet, normal ejection fraction. We did coronary angiogram, which showed non-obstructive coronary artery disease. Patient functionally is okay. He is active and mobile, and we had heart team discussion, and we decided for TAVI, mainly because the patient is advanced age and also his preference. He's an 83 years old gentleman. Now his STS risk score is not really high. Is actually 2.34 for operative mortality only. But the main issue here is the advanced age. So his labs is unremarkable, actually normal hemoglobin, normal creatinine, so normal labs. Next. And this is his ECG, basically showing wide QRS complex sinus rhythm with the right bundle branch block and normal BR interval. Next slide, please. Okay, this is the aortic stenosis, severe AS. We have a mean gradient of 50. Next. Next. An area of 0.73. And this is his coronary angiogram. The right coronary artery has mild disease only. Next. This is the left system. Again, mild disease, non-obstructive. Next. Okay, this is the lady, has proximal to mid, about 40% stenosis. Next. Okay, here we have the data from the CT, and as you can see, we have a big annulus. Is actually an average diameter of 26, parameter of 84.5 millimeter. Next. And again, generous sinuses, average size about 35. Sinotubular junction is 30 millimeter in diameter. Next slide, please. And coronary height is adequate. We have 70 millimeter in the left and 14 in the right. Next. Okay, so here the main issue we see here is the horizontal aorta is very extreme horizontal aorta. Here, as you can see, it's 90-degree aorta coming at 90-degree, and the angulation is also extreme. So we have the cusp overlap is an extreme spider view with caudal 73. I think this will be impossible to obtain, but probably we'll be working on the coplanar angle, which is a little bit more reasonable, and we probably can obtain that. Next slide, please. So the peripheral vasculature is okay, we have high bifurcation bilateral, but in terms of calcification and tortuosity, it's reasonable and size is good. Next. So the main challenge with this case is actually the horizontal aorta, very extreme horizontal aorta. And we are going to show you that despite this, we can still implant a self-expanding valve, as you will see. And the other problem in this patient, advanced age and right bundle branch block, so high risk for conduction abnormalities. And the last problem is the axis, vascular axis, because we have high bifurcation bilateral. Next. So our plan for today.
So before we discuss the plan, just I need to hear a comment from you guys. You know, horizontal aorta is, by definition, is more the angle more than 49. And most of these cases has been excluded from the clinical trials. If the angle is more than 70, it's very, very challenging. This is even more challenging because it's 90 degrees angle. So the what we call cusp overlap is impossible. We had to work on the coplanar view with all the challenges. So I need to hear from Dr. Fadi and Dr. Wael, what's their comments about the case?
Yeah, it's a very challenging case. You have many things to overcome. You have the femoral axis that is high, so here you have to be careful. Very tortuous and horizontal anatomy, so you need a device that's going to track. You have a lot of calcification, so you have to make sure you need to predilate well to have adequate valve expansion. And you have the horizontal anatomy of the annulus, where you have to decide which valve is the best. Are you going to take a balloon expandable where you can flex the system? Are you going to take an accurate or Navitor or something that can track? So many points that you need to overcome, but with the right preparation. But I think the most important thing in this case is to adequately predilate, because you have to come in a horizontal. If you're not going to predilate, you're going to get stuck.
Yeah. So in a horizontal aorta like this, a bad horizontal, as Fadi said, I don't wait until I surprised. I always use my big gun from the beginning. The most flexible device, the best stiff wire I have, which is a Meyer wire. As Fadi said, I always predilate, because even with predilatation, sometimes you don't cross easily. Prepare yourself to snare in case you need it. And I don't like balloon deflection.
Okay.
So that's the only thing.
Very good. Any comment from the audience?
Who would use a balloon expandable for this case? Who would use
Sundus, you like the balloon expandable. And I like self-expandable. So what is your approach? It's horizontal, super horizontal.
It's 90 degrees.
As horizontal as it gets.
Okay, now again, balloon expandable.
Balloon expandable has the advantage of having the flexor sheet to help you navigate the horizontal and overcome it. But again, with the new introduction of the new, for example, the platform for Medtronic for the FX is becoming more friendly. And also in our center, we had one experience with the Navitor in terms of a horizontal heart. So everything is possible, I will say, as long as it's in the right hand. Yeah. So if your hand is right hand, then it's going to be successful. But the key is, I think, you study the case, put the cons and pros of each platform you're deciding in, and go with what you're more familiar with.
Khalid, any comment?
Balloon expandable. Okay. Anyone have used the loop snare technique when they get difficulty getting the valve in the patient with the horizontal aorta?
Yeah, and especially if bicuspid, sometimes you cannot cross.
Yeah.
I didn't do it from the get-go. I had to remove the whole system and then reintroduce a snare.
Okay.
Sometimes there's a Chinese series of 100 patients. They did snare on everybody who is bicuspid and horizontal from the get-go. So this is something you can do in cases where you think you're not going to cross.
Or balloon sliding, or balloon, what you call it?
Yeah, that's an old fashioned. Like I really don't recommend to do it because I had one case with it and she had a bad stroke, honestly.
Okay.
Usually when you reach the limit you're going to use balloon, there is a lot of calcium.
Okay.
So you don't need to do the balloon. Just snare, contralateral access, load the snare, reach there, pull the snare, and you are okay.
This is actually with all systems. Now with the new systems, especially now with the FlexNav, you can negotiate through very tortuous aorta, even that acute angle and horizontal aorta. We didn't have a single problem with this in this case. And we didn't even use the back wire. We just used the confida wire, and the valve went nicely. So I'll continue with the video. So we pre-dilated with the, we pre-dilated with 22 balloon.
You will see. And the other problem in this
Can you show
patient,
us the
advanced
slide?
age and right bundle branch blocks for conduct. The last problem is the.
Okay.
So our plan for today is to implant 29 millimeter Navitor, and we are going from right femoral axis. We are using 2 ProGlide closure devices, and it's general anesthesia, which is not the standard, but the patient is unfortunately was not cooperative, so we had to intubate. And we are going to do pre-dilatation with 22 millimeter balloon. Post-dilatation only if necessary. We are going to use 25 or 26 millimeter balloon only if needed. And because the patient high risk for conduction abnormalities, we are planning to keep the temporary pacemaker for 24 hours in CCU.
So we dilated with the 22 balloon, and then we, oops, what happened? Hello everybody, my name is Mohammed Al-Mkhain. Okay.
So the main challenge with this case is activation bilateral Vitor, and
So this is the pre-dilatation. There's a confida wire in place. There's a big chunk of calcium there. Okay.
Which balloon did you use? Use a compliant or non-compliant?
No, Atlas Gold actually.
Okay, so non-compliant.
Yeah. 22 Atlas Gold. I know why he doesn't like it.
It just takes time to deflate, but I think for this anatomy, you need a good pre-dilatation.
Z Mid will do the war. You know, I'm from a congenital.
As you can see, also the systems is going nicely. I mean, we didn't have even a problem, even with this difficult anatomy. It's a very flexible system.
Very nice.
Very nice. And actually, it has an advantage that when you are deploying it, there is a button there which pops up when you are at 80% of deployment. So you cannot proceed. Your assistant might be not with you, actually. He's just rotating the wheel and for a full deployment. So once it's at 80%, it pops up. So you won't proceed unless you press the button again when you are really sure that your position is okay and you can release the valve. Also, coronary protection is there. It has large cells, so we didn't have a big problem with the coronaries.
Do you pace?
What?
You pace?
Do you pace during deployment?
No, I didn't actually. No, we didn't. Oh.
So for those who don't...
لا مشكلة خلها لي على. Hello everybody, my name is Mohammed Al-Mkhaini.
We are enjoying Dr. Muhammad.
لحظة حبيبي، ترى هو مخليه على الباوربوينت الله يهديه أنا ما أعرف اسمه.
It's okay.
For those who don't know the valve, this is also a sheetless system. You have a 14 French for the 23-25, 15 French for the 27-29. It's an intra-annular valve, long frame, and with a very flexible system, the FlexNav. And for the question of the pacing, the valve starts functioning very quickly.
Yeah.
So you don't have any drop. So
you don't get a drop of blood pressure like the others.
It's very stable. It has
the pressure will be there
layer.
while you are deploying even. Yeah. So you can take your time while deploying the device. So let me see here. Okay.
As if it's not advanced.
Sorry. Okay. So we are unsheathing it. As you can see, the anatomy, how it is. This is after the, this is after the release.
So, yeah, so stop here. Just.
Yeah. Okay.
Okay. So, Sundus, what would you do here?
You can take.
So what happened, and what do you think
I
should
don't know,
be
but
done?
it's like, there's significant calcification. We missed the part of the deployment, but I think the valve needs to be post-dilated. Like, I know there was despite the aggressive, or let's say, with using Atlas Gold, still we can see a waste there. I think it should be post-dilated, but just like carefully remove the nose cone and then assess the hemodynamics, or take another view. I would also take another view before proceeding, and then consider significantly to post-dilate. And I wanted to ask you, what balloon did you size based on your diameters before this?
Yeah, for post-dilatation, we decided from before that. We need to post-dilate, we'll dilate to 26 balloon.
Yeah, and I think in the previous Navitor generation, it was mandatory to pre-dilate and post-dil.
Yeah, actually,
and there was a talk about maybe because of the large cell frame that maybe you need some.
So the perimeter was 85, so you had a large anatomy. So maybe a 22 balloon was a bit small. But what you said is very important. When you see the frame like this, first of all, before releasing, you should go to an REO caudal, just make sure it's not compressed. But at this point, the most important thing is not to remove the valve with the nose cone. So you have to be very, very careful removing the nose cone.
Ahmed, predictor of enfolding.
Yeah, so I was about to comment about the nose cone just before he did. So yeah, I would be scared, to be honest, pulling the nose cone in this case. I think we'll take at least 3 minutes just to try to center the nose cone before pulling it. Otherwise, we might pull the valve. So enfolding here, I think we had one case of enfolding before. This is a bicuspid, and there is a severe calcification. We saw a dent of calcium even in the balloon when he was ballooning. This is all indicator for enfolding. Also, bigger cells valves known to have less radial force. This is also a bigger indicator for enfolding. This is a very large cell valve, which indicate that we're going to have a coronary access, but at the same time we lose from the radial force of the valve itself.
It's actually, if there is mild calcification in the CT, you don't need to pre-dilate with an Navitor. But if you have moderate or severe calcification, you need to. As you said, Ahmed, because it's large cells, there is less metal. It's a trade-off. More metal with other systems, you don't need to pre-dilate, but less metal, more cells. Then the price you have to do is just you have to pre-dilate, but you don't have to pre-dilate aggressively. Anyway, so we did post-dilatation with 26 balloon.
Oh, okay.
Yeah. This is the AI after the. This is ballooning with 26 balloon.
Beautiful.
Yeah.
So this balloon is Atlas.
Atlas Gold.
This one.
Yeah.
The only time I'm gonna use it in a regular case is when I have calcified, super like when I'm really expecting a recoil with the regular eye. So I want to make sure that the balloon is super stiff and do the job. This is one of the few indication I use Atlas Gold apart from fracturing valve.
Yeah, okay. So this is the final position. Actually, there's a mild PBL and verified actually with the, and mean gradient was 4 across the valve.
What about the
This is
gradient? Regurg.
because you'll see it now in the echo. It's just mild PVL, and after 24 hours it disappeared. And this is the natinol. I mean, usually they expand. That's the mean gradient of 5, and peak gradient of 9. And these valves usually they expand. For this reason, you see sometimes late, or even as early as 24 hours, the coronary obstruction and these self-expanding valves. This is if I go back, if I show you, you can see just mild PVL, anteriorly and posteriorly, and both disappeared after 24 hours.
Dr. Balghaith, what about the outside cuff that prevent, a good technique for sealing with this valve?
And this is okay.
And I think they were very aggressive in this case with the balloon. We don't use it too much like this balloon.
To conclude the case, finished this challenging case, the horizontal aorta with severe aortic stenosis patient. Sorry. Okay. High risk for surgery, and we implanted.
Yes. So this valve has this NaviSeal technology. So NaviSeal was a new. The old Portico did not have any skirt. So the NaviSeal, and in the trial, it decreased the rates of PVL tremendously. And I think
if you see their movie and how they demonstrate the NaviSeal criteria, you will be so happy.
It opens the diastole.
This is the only technology or platform with this type of NaviSeal. But I think I was watching the case very, very carefully. It works. No doubt that this valve, it works for horizontal. Most of our horizontal, just to go back, we done it with the balloon expandable, to be honest with you. But having this technology, I think some cases we might do it with this.
Yeah. Okay.
Even accurate works pretty well for self-expanding, but very good result. Very nice case.
Very good case.
Can you? We can.
But last comment.
Just for comment. A beautiful case and beautiful learning message from here, but which we can take as a message that's why balloon expandable valve is better in this very severe horizontal aorta. Whatever the material is. Whatever the material is.
No doubt.
What was the calcium score?
The valve's calcium score? I can't recall it actually. Yeah.
Maybe 10,000. I will not use balloon expandable. So let's move to the next case.
Okay. Can we move to the next case? Hello? How to exit? Yes.
That's a good case, honestly.
I don't know how to exit. Anybody can help? No. Okay, this one. Okay, great. Thank you very much. Okay, the second case. This is just to introduce the system to you. The Navitor valve. It has the NaviSeal, as Dr. Fadi said. This is just to mitigate the PVL. The cells are large to protect the coronaries, and the system, delivery system, is very, very flexible, and you can negotiate through different anatomies without any problem. This is the knob which I was talking about. It pops up when you are at 80% of deployment. So back to the case, a 68-year-old female with the following background: diabetes, hypertension, dyslipidemia, post-CABG 2011 at the University Hospital, hypothyroidism on thyroxine. Recently admitted in September at the Armed Forces Hospital with syncopal attack and found to have severe aortic stenosis. This is her labs. Hemoglobin is 13.9, GFR is 80, and this is her ECG, normal. And this is her chest X-ray. And this is the parasternal long axis zoomed. Actually, you can see it zoomed on the aortic valve. As you can see, it's fibrocalcified. And this is the short axis. As you can see, the LV function is normal. And this is apical three-chamber view showing the severe fibrocalcification of the aortic valve. And this is the Doppler through the aortic valve showing a velocity, a maximum velocity of 437 with a mean gradient of 50. And the annulus or VT diameter is 1.8. CT angio was done to evaluate the grafts. Limit to the LAD was patent, and SVG to the obtuse marginal is patent with mild to moderate stenosis at the origin. And this is the CT TAVI. So as you can see, the perimeter is 63, and the sinus is relatively small, and the height of the coronary, the left coronary artery, is 9.7. And she qualifies for 23 Navitor system. Any comment about the CT?
I mean, you have low coronary height, very small sinuses, and a small valve itself. So here you have to think about coronary obstruction, the first thing that glares from this measurements. So this is something to consider if you're gonna do a coronary protection or not.
The only thing blessing in her case is she had the lima to the LAD.
Okay, so that's important.
That's what made us to.
But yeah, so contrary to the evolute, who has a tapered, and the navitor is a tubular, so even at the level of the sinus, it stays the same size. So this is also consideration when you deploy this valve, is to know that the level of the valve at the level of the sinuses.
So this is very important comment. That's what I said during the valve in valve session. You have really to know the geometry, the engineering of the valve itself. Like, you know, now we have two valves. They are cylindrical, not flask shape or the opposite. The Navigator and the Allegra. So you have too many options. Just write the prescription, the right prescription for the patient. That is the most important message. Give him the valve, yes, give him the valve, you know, what you feel that it suits his aorta and for the future.
Okay, so this is the CT. The annulus is minimum 18.7, maximum 22, and the average is 20. And the LVOT is average is 20 also. There is a minor calcification at the non-coronary cusp, so no need for pre-dilatation.
Go back an image.
Okay.
So here, if you look at you have to also look at the leaflet length. If you look at the left leaflet, it's not calcified, it's not long, and doesn't have a lot of tissue. So that's also into consideration for coronary protection. So here I'm more comfortable in terms of the coronaries.
Okay, great. Also, the peripheries from down, the bifurcation is lower. The only thing, there was a nidus of calcium just near the bifurcation. We had difficulty in getting the pigtail from the left side because of the calcification, and we're really afraid that the system will not go through. But fortunately, it went. So,
And I think there is osteoporosis also.
yes, she's 80-something. What do you expect? Yeah. So this is while deploying. As you can see, we're at not really 80%, but still, you see the flow in the coronary is still there. Okay, this is before the final deployment. The valve is stable.
So you are pretty confident about the valve you are using. You did not use protection. You did not do an injection before you complete the release to make sure that your coronary is fine.
We have done about 27 valves so far, Navitor, in our center.
And to be honest, it's a little bit deep implantation. So
the landing zone for this valve, you can go deeper. You have the NaviSeal goes. You don't have to go at, since it's a tubular shape, you can go 5-7 millimeter and still have a very good sealing. So this is one of the advantages.
So this is the final, and there is just a trivial PVL, I would say. Yeah, you can see it.
Yeah.
And you see
And we're about 3 millimeter below the annulus.
and you see the crushed left coronary cusp definitely below the left main in this view. Nice.
This is her chest X-ray post, and this is her ECG post. And this is actually a paper from Japan, actually, showing compared. There's a comment from the authors here, compared to currently available transcatheter valves. The Navitor valve has the advantage of excellent device deliverability due to three-dimensional flexibility of low-profile working parts. And thank you very much.
Thank you.
Any comment or okay. Any question, comment?
So what was the gradient here at the end of the procedure?
3.
Okay. And another misconception, this is an intraannular valve,
Yeah.
but however, it has a gradient performance of a supraannular valve.
Yeah.
So the way the shape of design of the valve, the height of the leaflets, and the way they're sutured gives you hemodynamics of single digit in almost all cases.
And both valve, the accurate and Navigator is great valve for future valve and valve.
Yeah, but the accurate knee, the problem is not retrievable. This one is repositionable, retrievable, recapturable fully.
True, it's same as the balloon expandable. There's a way to deploy it.
Yeah.
If you deploy it in the right way, shouldn't be an issue. But I think you demonstrated in these cases how you can do very angulated aortas, very horizontal aorta. It's a very good system for navigation.
Yeah.
You have a large cells for coronary access. It's very important also just to know if it's a very calcified anatomy. You said there's a trade-off because of the large cells, less radial forces to do a predilation that is adequate to get good expansion. And then if you need to post-dilate or not. I think we have a question from the audience.
It's more a comment than a question.
Yes.
So we don't have much experience where I work in Switzerland and Oman. We spent recently, Navitor been recently approved in Switzerland. So we did only like 10 cases over the last 3 months. It's just to say that you can still use a 29 millimeter valve in a 14 French. We did a case recently, and I think we're going to publish it shortly. But just for you to know that, it's, as I agree with you, it's very deliverable. It's possible to, especially with, we did a similar case with very calcified aorta, very horizontal aorta.
You mean in the 14 French E-sheath?
Yes.
You mean in an expandable sheath? Yes.
Yeah.
So we were worried about the big size of the valve, whether it will be deliverable with the 14 French, but it did.
Yeah.
So just really a comment to add.
The only thing that doesn't go into 14 is an Evolut 34. You have to put a 16 French E-sheath. Very nice. Thanks for your comment.
Thank you.
So for the future valve in valve, this is the Navigator is a great valve. The shape of the valve itself, you can, as Fadi said, you can go deep little bit. Yes, it is. The frame is not that super strong, but with the help of the balloon, you can put the valve in a good position. But this valve, if you're going to do valve in this thin stent or frame, it will give you more space in the future, provided that the patient's having enough, left main high and coronary sinus. I think every day we are learning, and I don't think the TAVR in the future will be extremely difficult or impossible if you plan it early. What do you think, Faisal? The balloon expandable valve guy.
I'm no platform guy. I'm evidence-based guy. Yeah. But I just want to say that the demonstration of the case is excellent, and I just want to make sure that for the operator who wants to dive into a new platform, we take a message about the accurate or the Navitor now, that you want to use it in a horizontal aorta. And is there any other thing that you would like to reach for the Navitor as a platform? What are the patient characteristics that are going to make you say this is a perfect case for a Navitor?
Okay, thank you.
Any comment? Any question?
Ziad, we've been using the Navitor. What's your experience with this valve?
The microphone, please. The microphone, Doctor.
think really the flexibility is the most impressive part. So like the first case that you showed, it's a perfect example of where it can track very well. You can position it well. And then the system is very easy to use. It's very user-friendly. I'm usually on the system side. Fadi is on the deployment.
Yeah, but you see, because it's usually you don't have to pace and it's just stable. If you, we've used the old Portico system. The old Portico system, you had a lot of pushing, pulling. You had to reposition. With this valve, you just where you start, it just doesn't move much. And this addition of the stability later made us more confident in deploying this valve.
And the seal that you described gives you more confidence.
Okay. I'm just curious. I'm still following up on Dr. Faisal's question. What would be the ideal patient that you would recommend this valve to? As Dr. Weil mentioned,
if you have
prescribe the right valve for the right patient. So can you list that for us?
Tortuous aorta were really difficult to pass other systems, or you had to use a very stiff wire just to get your valve up. So very tortuous aorta, horizontal aorta. But this is what I would think of. Yeah.
And
but as Dr. Ghazal said, it's a very user-friendly system.
Yeah. So recently we did a case, 0 calcium, rheumatic aortic valve. She was having tortuous aorta, very frail lady. As a person, using other platform a lot, putting in my first 5 or 10 cases of navigator, I was so scared, like what's gonna happen? 0 calcium. Went very well, good stability, 0 paravalvular leak. And at that time, I start to believe about the NaviSeal system. It's a great valve, no doubt.
And also, some of the systems actually they will be under tension, and especially if you have an angulated aorta. The moment you release, that tension relieves, and the valve pops up. This system is very, I would say, very flexible, and there's no tension under the system when you are deploying the valve. Now the new the FX system, because it's only one spine, has some sort of similarity with the Navitor.
Okay, do you try to achieve commissural alignment with this valve? I mean, we're talking a lot of commissural alignment, and I might comment on this. So if you look at the valve, you have also the 3 posts, and you have actually like 3 paddles, like the attachment. So you can actually, the same thing that you do with the Medtronic or the Accurate, you can go to your cusp overlap view, and you can position one of the posts facing the right side of the screen. It's less visible, but it does work. Now they're coming with the new technology where you have 3 dots on each of the cusp on the sinus. So this way you can also achieve commissural alignment. I think that's an extra advantage. Similar dots that you see in the Evolut FX.
Okay. So I don't know, Fadi, if for this commissural alignment with this valve, it's an easy coronaries. Maybe you're gonna do the commissural alignment to prevent degeneration, halt, MALD. But I don't know if the concept of that the halt will be developed in Navigator comparing to Accurate to this and that, because we still the data is emerging and is not consistent. But now we have the belief that let's do commissural alignment. Go ahead.
Yeah, I mean, we do commissural alignment for many things. This is something we presented with the Accurate and London valve. In patients who don't have commissural alignment, you have higher gradient, higher rate of PVL, and higher rate of thrombosis. So I think respecting the anatomy is very important. Second is for your coronary access. You don't want to post in front of a coronary. And third, for your TAV and TAV, you're not going to be able to do basilica or any leaflet modification if you have your post in front of you. So I think trying to achieve commissural alignment is what every company is working on right now.
Dr. Moheni, conclusion?
There's nothing to say. I presented these 2 cases just to show the advantages of having a Navitor system. In each lab, actually, when you are starting, just keep yourself familiar with 1 or 2 platforms. Don't distract yourself with many platforms. There is no one platform which is, I would say, suitable for every single anatomy. But as I said, start with one or two, keep yourself familiar with. Maybe certain cases where really you need to get one platform. Let's say very low coronary, you might use accurate neo, because they say the upper crown usually caps the ostia of the coronaries, so at least to prevent caps the leaflets, so at least they don't obstruct the coronaries. But this is a very good system, and thank you very much for staying late with us.
Yeah,
have a good evening.
Yeah, we have one question from the audience. What wire do you use in case of coronary access post-TAV and TAV? I don't know if he meant what kind of guide.
We answered this in the last session.
Oh, okay.
So there is delay in the arrival of the question.
All right, that's good.
Well, with that, we come to conclusion. I would like to thank Dr. Mohammed Al-Mukhani for the excellent two cases he showed us with difficult anatomy. And of course, I will thank Dr. Fadi for his informative input as usual. And I would like to thank you guys for being with us. One last comment. He said, make yourself familiar with two devices. I would say, make your familiar with the anatomy of the device. Thank you very much.